Hi everyone. It's my great pleasure to be here and to interact with all of you. And this is a basic lecture on from where the signals come in electrophysiology. So we know that vision is not from the cornea or lens or from the the disposable parts of the eye, but from the non-disposable and the beautiful part of the eye, which is the retina. So we wanted to discuss what are the cells in the retina and optic nerve which contribute to the waveforms, and then what can be the artifacts. So the clinical visual electrophysiology has undergone a lot of refinement in the last more than 50 years, and now we have multiple ways of studying the function of the retina. So what is important to know is that whenever we put a flash of light on the retina, there is a change in the resting potential of the eye, and this will result in a biphasic waveform which is recorded using the electrode. So we're not putting any electric current into the eye, but we are just picking up the signals from the eye and magnifying them so that we can study them. So whenever the retinal function deteriorates, the light-induced electrical activity will also deteriorate, and it is very profound. It is not few microns. It will change by a huge amount. So this is what will happen. The light will fall on the retina, and the rhodopsin, which is in the rods, and will get photoisomerized. The proteins will change, the chemicals will change, and this will lead to hyperpolarization of the photoreceptors. And then the signal will go into the bipolar cells, where the rod and S cone will lead the signal to the on bipolar cells, whereas the medium and long cones will lead to the bipolar cells and the off bipolar cells. So then the signal will be carried on by the ganglion cells to the optic nerve. So the ganglion cells and the optic nerve don't generate that much of signals. So the direction also matters. Mainly those cells which are radially arranged, that is the photoreceptors, bipolar cells, Muller cells, and the RPE, they will respond more, and those which are horizontally placed, because the light is falling at an angle, they will have less effects. So this is how it will go, the signals, and the outer segments of the rods and the cones will generate the A wave. So that is a photoreceptor wave, whereas the bipolar cells will generate the B wave, which is the upgoing wave. So here we can see the retina, as the lights will fall on the photoreceptors, they will generate A wave, and the inner retina, which will generate the B wave, and the macular photoreceptors, which later Praveen will talk about, will lead to the pattern ERG or the multifocal ERG. And when we want to study the optic nerve function, we look at the VP. So the full field flash ERG, which is normal, is a mass response from all these cells of the retina, which is elicited by flashes of light of different strengths. So if we use dark adapted eye or light adapted eye and put different strengths of the light stimulation on the retina, the responses will vary. So you can see here how a normal ERG will look like and how an abnormal ERG will look like. So below you see the normal ERGs. We have put bright light on the eye in a dark adapted eye. So slowly we will see the B wave coming, and if we put more bright, then we can see the A wave from the rods and cones and the B wave from the rods and cones coming here. If we then light adapt the retina and then put the same light, same stimulus, then we see the waveform changes, because now only the cones respond, and they respond very quickly and very rapidly. And if we put flickering light, then it is not enough to stimulate the rods. The rods cannot respond to rapidly flashing bright light, so only the cone response will come. Whereas this is an example to show that when there is a disease in the retina, everything will change. So by studying the waveforms, we can know what is the problem in that patient. So we can also have different protocols, like the S-cone protocol. I'm not going to go into details, but if we use a different light, if we don't use a white light but we use a colored light on a different background, then different sets of cones will get stimulated. So like that we can look at different cells which are responding to the light, and that helps us to know which part of the retina and also which cells in the retina are affected. For example, all these patients were labeled as retinitis pigmentosa because they had pigment. Some of them had some RP changes, but our test showed that the ERG was not extinguished, which is what we expect in RP, but had a S-cone ERG. So pattern ERG, here the responses will come from the central retina, that is the macular area, and here we use a pattern because the cone cells in the macula will respond to to these changing patterns of cells, and some of this signal also comes from the ganglion cell, which she will tell in more detail. So this is how a pattern ERG will look like from the photoreceptors of the retina and from the ganglion cell, which is the negative wave. Then we can also have multifocal ERGs, which come from the on and off bipolar cells of the retina, and also from the inner retina and from the cone cells. So so these waveforms are actually a mathematical extraction of signals from the continuous ERG trace, and that is how we'll get the responses. The EOG is a change in the resting potential of the RPE. So the RPE, because of its chemical nature, there's an ATPase pump, there's a bicarbonate pump, so the ions are going in and out. So it has a resting potential of about 6 millivolts. That's a very lot of signal is there. And then when we ask the patient to move to different sides of the light and we record the outcome of that movement, we can see that if the light is put on the retina, then these signals become higher, and this is what we call as the light rise. So the signals will be low here, and as we increase the light, then the light response comes. So these responses are not from the RPE, they are from the photoreceptors, which then change the milieu of the RPE, and the signal will increase. So it's an indirect response. So an abnormal EOG in the presence of a normal ERG means that there is a RPE dysfunction. But if the photoreceptors are affected, since it's the photoreceptors which generate the signals, then we cannot study the RPE function. In those cases, we need to study the RPE functions by chemical changes, like using a bottle of beer or using acetosulamide or using mannitol. Then we can see the change in the potential of the RPE. The VP are the signals which are actually starting from the photoreceptors and then going on to the visual cortex. And so different check sizes are used. So here again we need to understand that if there is a retinal disease, still the VP can be abnormal. So in patients with unknown vision loss, or we are trying to find out where is the lesion, we should always do ERG, flash ERG, pattern or multifocal ERG for macular function, and then the VP, not VP alone, because that will be misleading. Now all these signals can be variations because of the physiological, technical or pathological changes. So there are many factors which lead to a change in these responses. So every lab should know that what is their own normative data and how the things will affect. And so all these parameters need to be noted down by the technician who's doing the test, so that we can what are the various things which can change. So to conclude, visual electrophysiology testing goes from a global response, that is the whole response, to regional areas like the macular area, the optic nerve area, and origins of most of these responses is well elucidated for clinical interpretation. And still there is continuous work done by scientists to find more and more signals and find more and more information about the function of the retina and its disease and pathology that we can see in the clinic. Thank you.